So Mycobacterium are rod-like gram-positive aerobic bacteria that actually have filamentous branching structures. The problem with mycobacteria is that they're very slow dividing and they may lie dormant for very long time periods. And they reside inside host cells, which makes it even more difficult to get to them, and they become resistant to antibiotic therapies very quickly. So you have Mycobacterium tuberculosis, leprae, and the primary reservoir are humans, and they have a very thick and impermeable wall. The treatment basically is divided into three separate approaches. You have the latent TB infection, the active disease, and the extrapulmonary disease, which could be pleural, lymphatic, GI tract, meningitis, and so forth. So typically isoniazid is the primary drug, and usually isoniazid is combined with rifampin, either for 4, 6, or 9 months. Now, basically the latent TB infection is also chemoprophylaxis, and the active disease is also very important to be treated. Multiple drugs are required because typically in the beginning it's a combination of isoniazid and rifampin for 9 months, and prophylactic therapy for family members with isoniazid for 6 months. So basically, if there is an issue of resistance, then we have to have a 4-drug combination followed by a continuation phase. Now, there are 3 subpopulations: they're very rapid growing, they're slow growing, or they have spurts of growth, which is followed by periods of dormancy. And then different anti-TB drugs differently. Isoniazid is the first line drug, then you have rifampin, pyrazinamide, ethambutol, and also gabapentin. So it's combined, can be combined with pyrazinamide and works best against the M. tuberculosis that's rapidly growing, and it's available IV-PO. Now isoniazid undergoes metabolism, and basically it is metabolized by the catalase enzyme, and often resistance may happen if there is a problem or a mutation in the CATG gene and there's no production of catalase, and therefore isoniazid cannot be activated. So it inhibits mycolic acid synthesis, which is a necessary component of the cell wall and is generally considered safe in pregnancy. The most notable side effects could be hepatotoxicity and initially asymptomatic elevation of aminotransferases, and then hepatitis. So AST, ALT elevation can happen up to 5 times the normal. Most happens within the first 2 months of therapy, and then they usually return to normal. Now, the newer data indicate that the rate of clinical hepatitis may be lower than previously thought, and of course alcohol use in pre-existing liver disease can worsen this. Peripheral neuropathy may happen, and this needs to be supplemented with pyridoxine, and you can have CNS effects such as anemia and lupus. So the rifamycins are 2 agents. They exchange with rifampin in special circumstances if it's intolerable, and rifabutin if there are unacceptable drug interactions. The second line agent basically is considered to be rifampin, pyrazinamide, ethambutol for slower intermittent growing, and they're extensively hepatically metabolized, and we don't need any adjustment in dysfunction. So inhibition of DNA-dependent RNA polymerase, they also covers gram-positive organisms, and be very careful because rifampin is a huge inducer of the cytochrome P450 system, and particularly oral contraceptives will fail. So rifampin can cause hepatotoxicity, thrombocytopenia. It can cause dose-dependent flu-like syndrome, but most importantly, with rifampin, all body secretions turn red-orange. All body secretions will turn red-orange, and there's complete discoloration of body fluids. Contact lenses would be destroyed. You can't wear that, and you need to avoid alcohol. Pyrazinamide is also used in combination, particularly if there's resistance or relapse, and it works against dormant and semi-dormant M. tuberculosis, only available PO. And it can cause hepatotoxicity, it can cause gastrointestinal systems, and gout arthritis. Ethambutol, excuse me, is also an add-on and given orally, and is safe in pregnancy, and it may inhibit the transferases, which is a mycobacterial enzyme that produces the galactan. Now, it can cause neuritis in both eyes. Active TB treated with fluoroquinolones, levofloxacin, moxifloxacin, streptomycin or capreomycin, cycloserine or P-aminosalicylic acid. Now, fluoroquinolones are like almost protein synthesis inhibitors, but they can inhibit DNA gyrase or DNA topoisomerase. You have moxifloxacin, amikase, and cycloserine works against positive and gram-negative organisms and inhibits cell wall synthesis. It can cause headaches, and pyridoxine supplementation may be required. Ethanamide works similar to INH. You don't need any adjustment for dysfunction. It can cause nausea and vomiting, some peripheral neuropathies, and hepatotoxicity. PAS is very similar to the sulfonamides. It competes with paraminobenzoic acid, and you don't need adjustment for renal dysfunction. It can cause hypothyroidism, GI symptoms,